I'm Rani Elkon from the School of Medicine, doing mainly bioinformatics. First, I would like to thank the three of you for the great talks. And my question actually refers to the three of you talking about genetics of cancer. None of you referred to the genetic variants that affect our susceptibility. The discoveries in the recent decade or so that were made by genome-wide association studies. And my question is why? Do you think that it's neglectable? It doesn't really have an influence in the future of personalized medicine in trying to prevent and predict?
I guess I'll can I have this microphone on, please? I'll test this microphone. No. I'm accustomed to speaking to medical students. I'll ignore the microphone. My talk focused specifically on the question of susceptibility to cancers in consequence of inherited mutations. I focused on mutations that actually matter, that is, mutations that have a demonstrable effect on protein function of genes which, when that function is lost, have a consequence that we can explain on pathways that matter for normal cellular development. There have been, over the past couple of decades, several $100 million spent on genome-wide association studies that have attempted with effectively random correlations to identify combinations of alterations, common alterations, not new mutations, of small effect that might predict cancers. All of the evidence that have come through our work, all of the evidence that has come through our work suggests that for, at least for familial cancers, there is no relationship between the various so-called polygenic risk scores and actual risk. The replicability of those studies has proven to be very low, and the level of cryptic population stratification in those studies has proven to be very high. I say that despite the fact that the studies are carried out technically extremely well. The problem is not with the genotyping. The problem is certainly not with the bioinformatics. The problem is with the underlying complexity of human populations, which are effectively impossible to completely take into account when one is working with large numbers of unrelated people. Hence, in my view, the focus on people who are demonstrably related to each other in families is a far more productive way to understand inherited predisposition. And when one focuses on people who are demonstrably related to each other in the same families, one learns that what matters are individual mutations of severe effect. In other words, the first of the three mutations that Bert talked about in his talk.
Yeah, and let me also add to that. I mean, one of the reasons that the mutations that Mary Claire described are so important is because they're associated with very high risk of breast cancer, ovarian cancer, and the others. Often what one gets from GWAS studies is relatively low risk, and the importance, the population importance of that became very obvious to us in the late 90s. A graduate student in our lab, Steve Lakin, discovered a particular mutation in the APC gene at codon 1307. It changed an isoleucine to a lysine, and it was very prevalent in Ashkenazi Jews. Very prevalent, very common. And we were very excited about it because we thought this was a population of obviously intelligent people who are used to genetic screening. And it conferred about a 1.8-fold increase in colon cancer. So we thought everybody would want to take this test because it gave them an indication that they were at increased risk. But it turned out there's very little interest from either physicians or patients because the degree of risk wasn't high enough to warrant enthusiasm. And so people are pretty smart. You know, if you show them that they have a mutation that really puts them at a lot of risk, there'll be enthusiasm for the test. For lower risk, they'll question its utility, and that questioning is good. So I think that's one of the reasons the GWAS studies haven't been as productive as the other kinds of studies that Mary Claire mentioned.
Hi, I'm Ruti Shai from Sheba Medical Center, and my question is to Professor Vogelstein. Regarding the random mutations and the importance of random mutations that you mentioned more than inheritance and environment. And I was wondering if we think that random mutations are so important because we don't know many of the causes of those random mutations. And if we knew, maybe it would go to another group of causes and not just random mutation being so important. And when I heard that, also I had a very difficult time with it because I think the public really thinks that random mutations are the cause, so why bother in prevention?
Yeah, there are two opposite sides of that coin. On one side, one has to be very cautious about doing exactly what you said, which is to discourage patients or individuals from listening to the good advice of the American Cancer Society and not smoking and not exercising and not doing all the good things that make people live longer and healthier lives. So one has to be careful about that. And I think most of the press in reporting it were actually pretty careful. But there's another side to it, which is particularly meaningful to me, because I started out as a pediatrician. Many cancer patients feel guilty that they have cancer. And this is especially true of parents with children who have cancer. Because if you're a parent with a child with cancer, you look on the web, what are the causes of my child's cancer? Environment and heredity. Well, I'm a parent. I'm responsible for both. A huge amount of guilt. Now, one cannot think of anything more horrible or tragic than having a child with cancer. But to add to that a burden of guilt, which is common amongst parents of children with cancer, I saw that when I was in the clinics, is just intolerable to me. So one of the satisfying outcomes of those papers that Christian published was we received literally hundreds of letters from cancer patients as well as parents who said, wow, for the first time, I have a scientific explanation of why my child or why I developed cancer. It's not my fault. I don't have to feel guilty anymore. So those are the two sides you have to straddle. You can't discourage people from doing the things they should. But on the other hand, you don't want to make people feel guilty for having cancer for which they weren't in control, and it's not their fault.
One issue that has not been discussed now is another aspect. We know that inflammation is linked to cancer, and we know that inflammation induces some microRNA like MIR21 and MIR155 that in fact are able to shut off a number of genes involved in repair, for example, MIR21 and 155, shut off mismatch repair gene, and MIR155 shut off RAD51. Therefore, high level of expression of this microRNA will shut down the repair that would cause a lot of mutation. And some of these mutations might be involved in cancer pathogenesis.
Professor Witz.
First of all, let me congratulate and thank you for these three glorious lectures. It seems to me that with the exclusion of the last remark by Carlo, the microenvironment of cancers was completely ignored. And my question is, did I understand the whole thing correctly? Do you really, and I'm talking about the three of you, do you really think that driver mutations is the only factor that would lead from the inception of cancer to the death of the patient, or do you assume that other factors, for instance, like inflammation, are also responsible for for cancer progression? And I'm stressing especially not initiation, but progression into metastases. What's your opinion?
But can I answer first? You are absolutely right. The microenvironment is very important. But essentially what you have in cancer is the genetic alterations, so the alterations are inside the cancer cell, but the penetrance of this alteration are regulated or determined by the microenvironment. I still remember that experiment where in a model of CLL, you get these mice all developing leukemia at 12 months. Now, if you cross those mice with a mouse that overexpress BAF, which is expressed by cell of the microenvironment, in fact, what happened, that instead of being 12 months, the leukemia killed the mice after 5 months. If you use the monoclonal antibodies against BAF, then the leukemia is retarded to 18 months, okay? So clearly, the effect of the environment, of the microenvironment on the tumor is measured. And therefore, if you affect the microenvironment, you might also affect the course of the disease. So I think that you have a very good point, that we should not only consider the genetic change that cause that malignancy, but how they are modulated, in fact, by the microenvironment, and how we can affect the microenvironment to affect the course of the malignancy.
And I could add to that, Isaac, an analogy. I mean, if you look at flu, right, common flu virus, well, what causes deaths is mainly not the flu virus itself, but the host response to the flu, right? So it's very analogous to mutations. The root cause of flu is the virus, but that's not the only thing involved in the disease. And similarly with cancer, the root cause is the mutations, but that's not all there is to the disease. Now, as geneticists, I think you can expect us to talk about genes, but we're all aware.
Well, I wanted at least to hear at least once microenvironment.
We are ecumenical on this point.
Hello. Yeah. So I also have a question. Yeah. So my question is to Professor Marie-Claire. The question is like you have seen various mutations in BRCA genes. So are there some specific mutations which are associated with specific subtypes of breast or ovarian cancer, such as some specific mutation associated with more aggressive cancers or cancers at an early age, such as TNBCs? So.
What a nice question. Within gene, it appears that there is not an association between the subtype of breast cancer and the particular mutation. Across genes, it appears that there is. For example, there is a gene called cadherin-1, which undergoes mutations, and the bearers of these mutations, their primary risk is for gastric cancer, cancer of the stomach. But bearers of loss of function mutations in cadherin also are at increased risk of specifically lobular breast cancer. So at that level, yes. Another example would be inherited mutations in the gene PTEN, which is an enormously important driver gene at the somatic level. People with inherited mutations in these genes have a number of systemic problems, but one of which is predisposition to breast cancer, and it is breast cancer of a very particular histologic sort. The cells look almost glassy. I mean, there's not a simple single name for this type, but it's obvious to any pathologist if she sees cells of this sort, she will come to a geneticist and say, does this person have either a somatic or inherited PTEN mutation? So your question is exactly on point across genes, but appears not to be so much on point across mutations within genes.
A question from a physicist.
Yeah, I'm not a biologist, so I apologize. In view of all the progress that you have described and all of our understanding, what are really the stumbling blocks for developing efficiently drugs? For example, it was mentioned that we don't have 2 drugs. Why? Why we cannot do it? And, okay.
The situation is similar to developing 2 drugs against any disease, whether it be HIV or... Now, from a genetic perspective, if the same mutation can confer resistance to both drugs, then it won't work. Now, in cancers, all of the drugs, the targeted therapeutics that are now used are directed to oncogenes, right? The kinase inhibitors, the prototype, Gleevec, et cetera, and all the other ones, the BCL2 drug that Carla mentioned, they're all directed to oncogenes. Now, how many oncogene alterations are there in tumors? 1 or 0 in most cancers. Remember, it takes 3 to get to a cancer. In general, 0 or 1 of them are in oncogenes, and 2 or 3 of them are in tumor suppressor genes. So one challenge is that tumors only have 1 oncogene in general. And the second challenge is it's theoretically impossible to develop a targeted agent against a tumor suppressor gene because all targeted therapies inhibit the proteins that they target. Tumor suppressor genes are absent. They're gone. So in order to target, you can't target a tumor suppressor gene. The best you can do is to try to target a pathway that it negatively regulates, which is much more difficult. It requires a much greater understanding of how these tumor suppressors work. But it's certainly not hopeless. It just requires more research.
But you mentioned also targeting the immune system. What about this?
You want to?
The example of synthetic lethality in the development of PARP inhibitors would be such a case. So synthetic lethality, where the consequence of mutations in a tumor suppressor gene is to abrogate function of a critical pathway, and then one also abrogates function of a parallel pathway medically in order to make the cancer more susceptible to yet a third drug, is a strategy that is, of course, as you know, of great interest. As Bert says, it's a much more complex strategy than targeting in order to reduce function.
I agree with Dr. Vogelstein about the issue of trying to hit the cancer cell by using 2 drugs or 3 drugs, because the probability that the cancer cell will be resistant to 2 or 3 will be negligible, okay? Now there are ways that we can start thinking about in order to make 2 or 3 drugs against the target. I talk about one. For example, BCL2 is dysregulated by the loss of MIR15 and 16, but other genes are dysregulated at the same time. So if we could make a drug against one of these, like the antibodies against the ROR1, we might get to that. We might have already 2 drugs against a single target. Okay? The idea of making 2 drugs or 3 drugs against a driver is a very good one, and if we could make more against 2 or 3 drivers, I think that the cancer will be defeated.
Okay.
I can't hear anything.
Please use.
Use the microphone.
I'm just wondering if we're really doing so poorly on chemoprevention, if we're ethically held back, set back in doing those trials in the high-risk families. There were a lot of high hopes 2-3 decades back, I think, and still very little progress and very little to offer the families in terms of, we have a lot to offer in terms of early detection, but not treatment.
What example of chemoprevention are you thinking about?
I'm just thinking of generally what's holding us from progressing in that field.
Oh, I see. Right.
What are your thoughts?
Right.
On that?
I thought probably perhaps what you have in mind is the possibility of using tamoxifen preventatively. Tamoxifen, as you of course know, is often used as a part of chemotherapy for breast cancer and is extremely effective for estrogen receptor positive breast cancer in preventing second occurrences. There was thought, 15 years ago or so, that the use of tamoxifen as a chemopreventive rather than surgery for families, particularly young women with inherited BRCA2 mutations, which yield estrogen receptor positive breast cancers more than estrogen receptor negative breast cancers, might be an avenue. There were really 2 reasons. It never caught on. It never even close to caught on. There were a couple of trials that were interesting. That never got even to a stage 3 trial. The reason that it never caught on was, I think, primarily that young women found, well, first of all, it's teratogen. Second, that the side effects, even in women who had no intention of becoming pregnant, the side effects were frequently bad enough that no one was willing to sustain it essentially for a lifetime. And the third is that it does indeed reduce the risk of estrogen receptor positive breast cancer, but it has no effect on estrogen receptor negative breast cancer. So I think that taught us that chemoprevention as an approach needs to have certain features that thus far no chemopreventive agent has had. It needs to be safe for young fertile women. It needs to target all the various forms of cancer that can accrue given inherited predisposition. And it needs to have side effects that are tolerable over a very long span. And thus far, no such agents have appeared. Just obviously, there's interest in it, but no agents have appeared yet.
Okay, if there are no more questions, let's thank the speakers for a fantastic morning. And thank all of you for taking part in it. Thank you.